Thank you for all those questions. We have a few more online, which I'll read out shortly. But can I invite Jim and Aditi to join us now for the workshop? Or learnings and focuses, we've called it. So we've had quite a spread of winter warfare. It's a great title, and I think we might need a few roaming mics. Here they come. Okay, so firstly to you, Michael, there's a comment regarding influenza and all the communication activities by the government and through primary care and manufacturers to the general public. What happens if the influenza vaccination rate for the under fives does not show any improvement versus the previous year? This could be the year of reckoning.
Yes, so fortunately, we now have our Centre for Disease Control in Australia, and this is very much a part of the focus, is making sure that we have the surveillance data so we know what's happening. And Dee, fantastic work through NCIS and others as well in helping us to understand what's happening. We know that we're dealing with a really significant backlash when it comes to misinformation and deliberate disinformation, and we all need to be really vigilant and on top of tackling that. We've seen things dip. I hope we're going to see things come back up again, and I hope that that's going to be happening soon. But fortunately, we will have the data so we know what's happening, and then we can target the initiatives that we've got to try and turn that around.
Okay. And for Jim, this came through in your talk. When I work in emergency department, I manage chest pain as possible myocardial infarction. Should I manage a viral infection as a prodromal myocardial infarction?
Thanks. It's a really interesting question. So there is some work that, to partially answer your question, that if influenza vaccination as a secondary prevention with acute myocardial infarction does reduce subsequent myocardial disease. And there's, I think, some growing evidence around RSV for that as well. Then to come back to your question, which is if I see a viral infection in the context of someone who already has a history of ischemic heart disease, then it's logical but not completely proven that either by treating the viral infection or with a form of prophylaxis, there may be some impact. We don't know. The reality is that we think the relationship between the viral infection and the acute myocardial events is mediated by inflammation, and we don't know what impact any intervention will have at that point has on that inflammation.
Okay, thank you. Are there any questions from the floor? The microphones are in the centre of the room. While you're coming up, a question here, what percentage of children under 5 for influenza would you expect to be by 2030 as a function of the NIS? I guess it's the NIP, is it? Considering the national average is only 26. I'm not sure if that was in Aditi or with Michael.
Well, we've never had targets as such, but we've got aspirational targets for vaccines such as measles. We've not had that for other vaccines, and it may be worthwhile considering. I think it would be year-on-year increase that would be an ideal situation, and try and go as high as we can, because as Stephen mentioned in one of his questions, how do we get to where the people really need the vaccine? So exploring more at a lower level where there is a need to get the vaccines to. So there could be many issues around that, such as access issues or other hesitancy issues and other related issues around that. So one has to tackle that. But no targets there. But right. I would expect a year-on-year increase. Thank you.
Please.
Hi. I just wanted to, there were a couple of presentations yesterday that showed the impact of LAIV on pediatric influenza coverage, and the short answer is about 4%. coverage this year is about 4% higher at 20% in the under 5s compared to 16% last year. So it's quite a modest increase. And that data you presented today, Aditi, showed that about 3/4 of the flu doses given to under 5s were flu mist. So there's been a lot of replacement, but relatively little increase. So we're still at around 20%. So I guess the question is, and one we'll have to think about this afternoon too, is clearly something really remarkable has to happen, has to be done if we're going to get reasonable coverage for children for influenza vaccine. And do you on the panel have any suggestions?
Anyone?
Possibly easiest for me since I don't have any governmental obligations around policy. But I think in the current scenario, any form of mandate has substantial risk as well. And so I think the philosophy of maximising the opportunity seems to be the best way to go. I think with a combination of education around the impact, especially in areas like preschool, etc., and maximising the opportunity for children to get vaccinated, and given what appears to be the improved acceptability of LAIV to parents, I think leveraging all of those in the absence of anything that resembles a mandate is likely to be the most effective strategy. And then once we move into the school-age population, the experience from the UK shows you can, in a community where overall their immunisation coverage is probably lower than Australia's, the high level of school-based coverage for LAIV I think is likely to be the way that, should it be funded, should be implemented.
Right. Paul?
Now that Jim's mentioned the M word that everybody seems to want to avoid nowadays, my question is for Professor Kidd. Should workers in aged care be required to be vaccinated? I mean, we've now gone to the step of saying you must provide access and a program in aged care. When I look at the data, it's still terrible. When I look at the mortality from COVID in aged care, it's still terrible, particularly compared to the rest of the community. If you're a nurse working in neonatal intensive care, should you have a personal decision as to whether or not pertussis is a vaccine that you feel you should have in that setting? And should all workers in aged care have a requirement as part of conditions of service to have respiratory vaccines when they become available?
Thank you. So I assume the M word is mandatory. Is that correct? Okay. All right. Just getting it right. Look, we do have mandates for vaccination, or at least evidence of past infection with healthcare workers in a number of settings around Australia. So this is not new. We have much more stringent infection prevention and control requirements in our residential aged care facilities across Australia. One of the consequences of how dire things were during the early phases of the COVID-19 pandemic. We also have a moral responsibility as people providing care to other people to make sure that we're not putting people at risk of these awful diseases. Look, as the Chief Medical Officer and the first GP in this role, I would like to see 100% of people protected against vaccine-preventable diseases. In Australia, I need to defer to the research experts as to what the priorities are, what the priority populations are, where the greatest impact is going to be had, the cost-effective question that was raised before as well. So these are complex. These are complex issues. We did have a mandate in aged care for COVID-19 vaccines. I had the privilege of being involved with that when I was in the the deputy role formally. I was impressed by how quickly we got to 100% of people working in aged care vaccinated, as not just as a consequence of the mandate though, it was also that moral responsibility at the time and people taking it so seriously.
Another question online, or statement. Is there a move to standardise the availability and age groups for LAIV flu vaccines for children across Australia, particularly useful for children who have a fear of needles? Aditi or Mark? Okay, Michael.
Well, as we've seen, the programs are being initiated by different states and territories at the moment, and that's what often happens with the introduction of new vaccines into Australia. One of the states or territories will initiate something, and we'll see how that works. The researchers will be looking at how effective the approach is, what the uptake is. That then gives us more evidence for ATAGI and for PBAC and the other advisory and decision-making groups to be making to government.
Yeah. Just a final question from me. I'm a grandfather, which is great. So over 10 years, I've enjoyed 3 grandchildren. But we also very deliberately, as grandparents, we're very careful about what vaccinations we've had and had not, and decided to make sure we're updated, particularly with DTP. So I wonder if there's an avenue for education for grandparents to understand that they can not only get infections, but pass on infections, and some kind of education that grandparents might go to their GPs and look at this, because I think it's an area that's missed, at least in certain circles I work around. They don't even think about it.
Gary, I think you are on the cusp of starting a new advocacy campaign among the grandparents of Australia, and I hope your grandkids are impressed that you're speaking at the Marvel Stadium today as well.
Thank you, everyone. Thank you very much to our speakers. If you would join me with a round of applause. Well, we're sending you off to morning tea now, which is, I guess, over here. And as I mentioned, bathrooms are behind the registration desk. And please don't forget our supporters, industry, who's supporting this meeting. I don't want them to feel lonely today, so please go and have a chat to them. There they are, waving.